I would love it if you could share with our participants today your journey with diabetes as a transplant recipient and also during the time of COVID.
So thank you very much. Yes, my journey began in 2003 when I was first diagnosed with type 2 diabetes. Growing up African-American, you really didn't hear anything about diabetes, so to speak, but you always heard the terminology sugar. I knew that diabetes ran on both sides of my family, but there were no educational resources or any pre-educational resources, I should say, talking about how to manage diabetes. So again, I was first diagnosed in 2003. My diabetes at that particular time, my A1C was 11.7 out of 12. My glucose level at the time that I was diagnosed was 748. So those numbers really didn't mean anything to me, but the physician really had to do quick education at that particular time. Then 10 years later, in 2013, in April of 2013, my primary care physician was also an endocrinologist, and she informed me that I had 35% kidney function and referred me to a nephrologist, where later that year, December of 2013, I began peritoneal dialysis. Doing peritoneal dialysis on various medications and still trying to manage my diabetes was very challenging, even to the point of being on metformin, the pill form of metformin, and being on 2 different insulins. One insulin I would take once a day, and another insulin I would take about 15 cc's before each meal. April the 21st, 2017 is when I received my kidney transplant. I woke up from the surgery and the kidney did not, due to delayed graft function. So 5 days after receiving my kidney, I was told that I had a blood clot in my neck and I needed a second surgery. 3 days after the blood clot surgery, I was told that I was bleeding internally, so I needed a third surgery. 17 days later, I had a 4th surgery where they removed the J tube and created a laparoscopic peritoneal window for me to drain internally. So after 4 surgeries and 33 days in the hospital, I was released to a rehabilitation facility for 6 days and then released home. And my kidney finally woke up on the 47th day. So from that point, my transplant coordinator told me, she was like, well, Mr. G, your labs look good, but you're still obese. And if you don't do anything about your weight and to better manage your diabetes, you're going to literally kill your kidney. So at that time, I was referred to a weight loss program where my weight loss doctor put me on a low carb, high protein diet. So in joining the task force, August of 2019 is where I really learned a whole lot about the difference between a GLP receptor agonist versus SGLT2 receptor inhibitor. So after the conference in January that the Diabetic Kidney Disease Collaborative had, I sat down with my weight loss doctor, and because I also have a family history of heart disease, and because of the diet that I was on, we decided at that time that I would utilize the GLP-1 receptor agonist. And since that time, everything has been going well until March of this year, where I tested positive with COVID. One of the interesting things was because of all the anxiety of being isolated, dealing with people that, you know, the no mask movement versus the people like myself that are at risk, that want to wear masks, all the, you know, the social and civil unrest that was going on. There were a lot of challenges, you know, trying not to emotionally eat, trying to manage my diabetes as well as my kidney care. And I just want to attribute my transplant and my weight loss team for making themselves available every step of the way, you know, through telehealth, through FaceTime, through Skype, and just regular emailing and calling me. I was able to talk to all of my physicians, even to the point of being prescribed a particular medication when I was COVID positive, which led to me having adverse issues with COVID to the point that I had to be hospitalized for observation and further testing. So even after testing negative, now I'm dealing with the remnants of COVID in the form of post-infection fatigue syndrome. So, you know, dealing with the aftermath of COVID and still managing my diabetes has been challenging, but it is doable. And I can say that, you know, that initial 11.7 A1C, I am now, as of June of this year, at a 4.8. So for those out there that don't think that it can be done, it really can be done. It just takes a lot of hard work, a lot of dedication, and a lot of encouragement from your care team. And I'm just so grateful for my care team, and also to be a part of the task force that it has really prepared me to be able to go out into the community and take different literature and medical innovations to where the most affected and underserved communities would not get. And now, you know, from everything that I've gone through, I consider myself a hope dealer, because now I can take hope into the community where there wasn't hope for decades. So I'm just so grateful to be able to share my story. And thank you again.
Well, thank you, Patrick. And I think, you know, as I started out saying, you have this powerful voice. I think you've made that incredibly clear to everybody listening today. We're going to have a time afterwards for participants to ask questions, but it strikes me, you know, you are an exceptional individual, and, you know, really have taken charge of your own healthcare. Is there anything, and maybe I'd ask David and Kathy to weigh in too. I think as healthcare providers, we need to, you know, listen and learn from patients. You know, how can we help, and how, you know, how can we get the healthcare providers to take, you know, really be champions of these new medications, which, you know, you are. So.
Well, for me, one of the things that's been very encouraging is just being a part of organizations that will allow the patients a seat at the table. You know, a lot of times when we go to medical appointments, you'll get interrupted within the first 11 to 15 seconds, and then you'll get a sermon on being non-compliant, instead of somebody asking you, well, what happened? What prevented you? What barriers were in place that prevented you from better managing for your care? So I think now, since patients are now being more vocal about their physicalities, their afflictions, and the emotions of living with a chronic disease, it can help clinicians to better care for them and also kind of tailor treatments and solutions individually that will fit that particular lifestyle.
All right, I'm going to, we're going to have further follow-up on that. Outstanding points. And David, I'm going to actually throw the next question to you.
Sure, absolutely.
I think, you know, the O'Brien Kidney Center is all about innovation. And we heard this morning, you know, about some really incredible advances. There is a lot of innovation, we think, is coming down the road for patients with kidney disease and diabetes. So where are we? And, you know, can you give us any, you know, look into a crystal ball and tell us where we're going?
Yeah, sure. I think that's a very important point because it picks up on what Patrick was saying about having some hope for the future around the treatment of complications related to diabetes. And I think that's important for patients. It's important for you know, healthcare practitioners to have that hope too, to have something in our armamentarium to use to reduce risk over time. And we've had, you know, over the last 20 years, we've essentially had ACE inhibitors. That's pretty much been it, beyond, you know, control of glycemia and so on, which really has a very modest effect on stopping kidney disease progression. So I think the basis for looking forward stems from the observations from trials like Credence and now with DAPA-CKD. I think we have a lot more optimism for the near term and for the longer term as well, for people with a wider range of clinical phenotypes, including people with non-diabetic kidney disease who seem to benefit to a similar degree at least as those with diabetes with SGLT2 inhibitors. And we know that now from DAPA-CKD, which was presented all of 11 days ago, I guess. So that's super exciting and really extends the observations from Credence to people with a slightly lower level of kidney function down to 25 and to people with slightly lower levels of albuminuria. So I think these trials are so important because they give an indication of how we can start to chip away at that residual risk that patients have despite the use of therapies such as ACE inhibitors or ARBs that we've been using for so long. And looking into the future, we now have at least top-line results from the Fidelio trial with an entire new class of medications. And we know from the press release that the primary and secondary endpoints were positive. So we don't have any details publicly, at least yet, but that's certainly very, very optimistic and suggests that there will be another therapy on top of ACE inhibitor ARBs plus SGLT2s. And now we'll have to figure out in conjunction with patients and the tolerability and the safety profile, of course, how these therapies can be used on top of the new standards of care, including SGLT2 inhibitors. And then looking to the future, we heard from Dr. Drucker earlier about the GLP-1 receptor agonists, which, like the mineralocorticoid receptor antagonists like finerenone from Fidelio, probably work in large part through reducing inflammation. So they work through a whole different mechanism compared to these hemodynamic-centric medications that we currently use, like RAS inhibitors and SGLT2s. That's tremendously exciting. And then in addition on the horizon is EMPA-KIDNEY. And EMPA-KIDNEY will hopefully, depending on what the results show, will hopefully extend the observations that we have from Credence and DAPA-CKD and pushes that GFR threshold where we're comfortable using these therapies even further towards the left, down to GFRs of 20 if the trial's positive, and also really extends the results of those older trials of those. They're not so old, they're 11 days old, but the previous studies, I should say, will hopefully extend them to fill this huge gap that we have in terms of people with neither normo or microalbuminuria, which no therapy has been shown to be effective in terms of reducing the risk of hard endpoints, either losing significant kidney function or dialysis risk in those patients with low function, but with normo or microalbuminuria, which, when I'm in clinic tomorrow, I think we have about 25 patients in clinic tomorrow. I expect that roughly a quarter will have low function with normal or microalbuminuria, a quarter or more. And so that'll mean that I'll see probably about 5 or 10 patients tomorrow who have that kind of phenotype. And right now I have nothing to offer them in terms of evidence-based therapy to reduce risk. So in terms of the future, the summary is hopefully we'll be able to flatten that curve in terms of CKD progression and be able to further reduce risk in patients for whom we don't have any good evidence-based therapies, including those that reduce hemodynamic injury and those therapies that reduce inflammation and fibrosis-related injury over time. So I'll be quiet now so we can get to some other questions too.
Yeah, a great overview. And I know there's going to be a lot of questions either from us or from the participants as we move forward, and also to get a view from the north. I think, you know, us down in the US, I think there's some differences. So I'm now going to throw the $1 million question to Kathy, something that we think about a lot. There are all these incredible new therapies on the horizon and also already here. Yet how are we going to convince nephrologists, healthcare providers to start getting these therapies to the patients who need them?
So thanks, and thank you for welcoming me back to Northwestern. And actually my roots run even deeper. I went to medical school there too. So I feel very comfortable in the Chicago environment, even from a distance. So hello to all my friends in Chicago. You know, this is actually really a critical issue. As David pointed out, we have known about the benefits of ACE inhibitors and ARBs for diabetic kidney disease and other forms of proteinuric kidney disease for over 20 years, and I would say it's really over 30 years. But frankly, it's been a failed experiment, because when we look at data from clinical practices in the real world, the utilization is less than 50% and probably closer to 25% in the United States. Now, there may be a lot of reasons for that are beyond the scope of our discussion, but the truth is we haven't even done what we know very well. So in order to deliver on the promise of the new therapies, we have to do a much better job at dissemination implementation. You know, Patrick's story is very telling in a lot of ways. You know, reading between the lines, he was diagnosed late, not only with diabetes, but with kidney disease. And I think that doing a better job starts with better awareness and detection, because we have to have awareness and detection in order to intervene. And I only wonder if we could have diagnosed Patrick earlier. And even if we had done what was available at the time with ACE inhibitors or ARBs, it really comes to my mind the question of whether his kidney failure could have been prevented. And how many more patients have suffered because we didn't do a very good job of, first of all, identifying their diabetes, and second of all, identifying their complications and intervening in a timely manner. We are going to have a menu of therapies, as David pointed out. The SGLT2 inhibitors are now recommended as first-line treatment for people with diabetes and kidney disease by virtually every professional society, whether it's a kidney group like KDIGO or a diabetes organization like the ADA, the EASD, and even the European Society of Cardiology and American Heart Association have weighed in on this. But remember that those trials were all performed on a background of ACE and ARB use. So first off, we have to get our house in order and get patients on ACEs and ARBs. And then we need to get them on SGLT2 inhibitors. And you've really led a tremendous effort through the Diabetic Kidney Disease Collaborative at ASN to really begin to work on this. But it really has to start with, frankly, you know, a public health campaign around awareness and detection. And then we need to work with people, not just providers, but with patient groups, to really demand, frankly, that they get the current standard of care. And ACE inhibitors or ARBs, along with an SGLT2 inhibitor, is the current standard of care. It is not coming, it is here. And then, as David said, there are now other therapies that are close on the heels. We have the finerenone, the non-steroidal mineralocorticoid antagonists that we're anxiously waiting to see the data, but we do know that they hit all the primary endpoints too. And then Dan Drucker's talk was absolutely fabulous. We're still trying to understand how GLP-1 receptor agonists work, but there is strong evidence that they're anti-inflammatory at the level of the kidney as well as elsewhere, whether there are receptors there or not, whether it's a direct or indirect effect. And the really important point of that is these are complementary to the other therapies. We're going to have to learn how to phenotype patients better, because we can't also keep adding drug on drug on drug on drug. There's only so much people can tolerate or afford. So we're going to have to learn how to identify which patients, which drug at what time, which is an active area of investigation as well. But I think that finally the kidney community has come together with some powerful advocacy coming from patients, but also for those of us who take care of them. But I think that has to come first. All of the science is great, but it won't translate into clinically meaningful benefit unless we get it to the patients. So I'll just stop there and be happy to answer any questions or hear reactions from others about this issue.
Okay, well, I think we'll open it up, and I think, you know, I'd love to hear Patrick and David, your thoughts also about, you know, getting these therapies out. Maybe David, I know we've talked a lot about this, and I hear a lot about it from nephrology colleagues that, you know, they're just not comfortable yet necessarily prescribing them. So yeah, tell us your experience about that.
Yeah, so I think the point that Kathy made about ACE inhibitors is really critical and is very sort of translatable to how we will hopefully avoid those issues with the SGLT2 inhibitors. And for, you know, nephrologists, I think, will hopefully become comfortable with them quickly and should. And we have a large precedent for being comfortable with drugs that have many off-target effects, like ACE inhibitors, for example, which have kidney protective effects that are, you know, independent of their original intent, which was blood pressure lowering. And similarly, the SGLT2 inhibitors are renal protective that are not necessarily only independent of blood pressure they're lowering, they're also independent of their effects on glucose lowering. So I think our ability to get comfortable with a new drug that has a sort of a pleiotropic effect on many different pathways that are beyond just glucose lowering with an SGLT2 inhibitor will hopefully be amenable to us using these therapies in a broad way in the future. These therapies are really quite easy to use in the end. So it turns out that we don't have to do a lot of, you know, diabetes related adjustments and other glucose lowering therapies unless patients are on, you know, drugs that cause hypoglycemia and patients have tight glycemic control. It's rare that we have to back off on other agents in a real significant way. Maybe except for people with, you know, A1Cs of 6.5 or 7 on large doses of insulin as an example. And similarly, we generally don't have to back off on any of their blood pressure lowering or diuretic related medications, except if patients are frankly hypotensive or frankly volume depleted. And for those patients, we're used to, as a nephrology community, we're used to backing off on therapies anyhow and adjusting antihypertensives. So it's very, very easy to use. And in the trials, there really wasn't any guidance around adjustment of other background medications. So the benefits that we're seeing in those trials were not a matter of, you know, very, very careful control and adjustment of other medications. Patients were randomized to drug or placebo, and then the biochemistry and the endpoints were accumulated over time. So I think these are important lessons for us, and we have to be comfortable using these medications because they really are very, very straightforward to use and don't represent any kind of significant obstacle once they've been used a few times.
Okay, I'm going to, I have a couple of questions here, so I'm going to read them out to the panel.
Great.
We have, what can be done to increase the speed of moving drug innovations from approval to getting them prescribed to larger number of patients? So that sort of follows on our question, and maybe adding into that, you know, talking about paying for these medications. So I'll open it up to anyone who wants to address that.
Well, Sue, I'll be happy to start. I think You know, an important stakeholder group in this are the payers and the pharmacy benefit managers. It is an educational issue, but beyond that, it has been difficult to get these drugs even when they're prescribed. And part of the problem is that we've been sort of firewalled from the people who pay for these drugs and make decisions about what they're going to cover. And I think basically my approach would be we need to bring them in as stakeholders to these various groups, like, for example, the DKD Collaborative. You know, still in the States, it's in some places to get an SGLT2 inhibitor, they're not recognized now as anything other than anti-hyperglycemic agents. So they won't be authorized unless a patient has failed a series of other anti-hyperglycemic agents, when that's not even the reason that we're prescribing them. So, you know, that's where I see a barrier, and I would prefer to make them collaborators and become part of the solution, to get them involved earlier. So when the guidelines change, when the trials come out, they're at the table figuring out how to do it along with us. And so it is the payers and it is the pharmacy benefit managers, not just the drug companies. And I think all of those groups are really critical, because drug companies make the drugs, and pharmacy benefit managers and payers determine who gets what. And so I think in addition to education of patients and providers, those are critical stakeholders in terms of getting the treatments to the patients.
Yeah. I don't know, David, if you wanted to comment on the situation in Canada, which is a bit different about paying for drugs.
Yeah, so the system for paying for drugs is heterogeneous in Canada. It's province dependent, which is the equivalent of state dependent, and depending on where you live and your age, there are different ways of covering drugs and costs, including private and public health insurance. And over the age of 65, at least in Ontario, SGLT2 inhibitors are covered as part of our universal healthcare system. So depends on a variety of factors, but certainly in our older patients who are much more likely to use these therapies, at least in my healthcare environment, the same barriers don't exist. And from the little that I know around rate of usage of these therapies, it does help certainly facilitate the use of these therapies in appropriate contexts, especially for newer indications. And as Kathy mentioned, you know, we're not using these therapies for their glucose lowering anymore, and we really have to get away from that, and we have to get away from these old, obsolete GFR thresholds that are completely irrelevant to how they work in terms of preventing dialysis outcomes, preventing hospitalization for heart failure, preventing atherosclerosis-related cardiovascular disease endpoints. These are completely separate from the glucose-lowering therapies. So we have to educate the folks who are responsible for making these kinds of decisions, so that they know that not only will these benefit patients, but obviously if we prevent these extremely expensive endpoints, which are expensive to patients in terms of their quality of life, their morbidity and their mortality, but also to our healthcare systems. It's expensive to be on dialysis, to our communities and our societies. It's expensive to have endpoints and end up in the hospital. I think that the math becomes actually quite easy, not only in terms of benefits for patients, but also at a societal level.
Yeah, absolutely. I have another question, and I'm going to direct this to Patrick first. So we have a comment that this participant agrees with Dr. Tuttle and quotes a recent Journal of American Society of Nephrology article that was published about screening for chronic kidney disease. And the author recommended that clinical trials are conducted to support early detection. So this participant says, from my point of view, how can there be any opposition to early detection of chronic kidney disease? So maybe Patrick, sort of following up on Kathy's comment about, you know, late diagnoses, and this is clear that also occurs for patients. Maybe you could make some comments from your perspective.
The CDC and other organizations have already put out the most affected populations. African Americans, Hispanics, Native Americans, and Alaskans. So I would think that those groups would need to be targeted primarily with pre-diabetes, pre-kidney education, but also to involve other stakeholders as well as, people from the diabetes community, people from the nutrition community, all coming in, as well as insurers, practitioners, and everybody having a seat at the table with no ownership, and allow the patients to kind of, tell their story and what they're going through. Because even though you have many people in this country or all over this world that are dealing with kidney disease and diabetes, none of us fall the same way, and all therapies don't work the same way. So you can't lump everybody in the same boat. But as people on the boat and people sitting at the table, you can certainly allow our voices to be elevated, because if not, we're going to continue to spiral out of control.
Yeah. Yeah, I think without having, the patient voice and patient, it's going to be critical to make a change. I see that we've got a question, and I think Ashley's going to unmute Nancy. So I'm gonna let Ashley do that. We might actually get a verbal question. Okay, we're just waiting to see if Ashley can unmute. Maybe while we're waiting for her to unmute Nancy, I'm going to ask, there's another question on the side. This comes from a participant. How should SGLT2 inhibitors should be managed in the context of primary and specialist care? What type of model could coordinate primary care physicians, endocrinologists, nephrologists, and cardiologists, so that we get an impact on glucose control, heart failure, and kidney disease progression? Yeah, I know a number of you are thinking about this, and I think Patrick, you may, your story and all the individuals and impact that have, that help manage and you interact with is important. Maybe, I don't know, whoever would like to address that question. So this is the multidisciplinary approach.
So this is Kathy. I'll be happy to jump in on this one. I think everybody owns this. So, there are so many patients for whom these therapies are indicated, whether it's diabetes, heart failure, or chronic kidney disease. It's not one, it's all of us. Sure, endocrinologists need to be comfortable with use of SGLT2 inhibitors for obvious reasons, but so do cardiologists and nephrologists. It's not someone else's job. It's our job. And like David said, this is not too difficult for us to do. We do much more difficult things, frankly. And it doesn't take very much effort to learn how to do this right. And I actually think it should be whoever sees the patient and determines they have an indication should start the therapy and monitor it. That's not to say that if a person sees multiple specialists that they might not, they might make an adjustment or something, but I think that's where communication is important too. But I don't think we should refer them to another specialist to start the medicine and monitor it. It's our job to do this. And I think that's true in cardiology and in diabetology or endocrinology and primary care. And then with good communications between specialists so that basically the patients aren't passed off from visit to visit to visit saying it's somebody else's job. It's it's the job of all of us. And we can do this, and it just shouldn't be that difficult. And like David said, get ready. This is the first of a string of new therapies that are going to come that will benefit our patients, but will require some attention. You can't just fire and forget. These are people who will need certain types of monitoring, counseling, and careful attention. But that's our job. And if that's not our job, then maybe we should be doing something else.
I just want to echo what Kathy said, and I want to put this in the context of an ACE inhibitor. These drugs are much easier to use than ACE inhibitors, and I see way more side effects from ACE inhibitors and ARBs. In terms of kidney injury coming to the hospital, hyperkalemia, blood pressure reductions, angioedema, all the issues that we have with ACE ARBs, they're much harder to use and adjust in my experience, especially in people with low kidney function than the SGLT2 inhibitors are. And I agree that no matter what your area of specialization, renal, endocrine, cardiac, or PCP, we all have to be comfortable using them just like we do with an ACE inhibitor or antihypertensive. We all have to be able to use an antihypertensive. We all have to be able to use an SGLT2 inhibitor very clearly.
Yep. Yep.
Yeah, I'd like to also share something. After my transplant, I was in the midst of a tug of war between my endocrinologist and my transplant team as to who was going to manage my diabetes. And it really got nasty, even to the point where my endocrinologist was like, you tell them to monitor your kidney function. I'm going to take care of your diabetes. And it wasn't until I went to my weight loss doctor and started talking to her about these different innovations that my weight loss doctor was like, look, you need to get with your transplant team and listen to them. And when I talked to my transplant nephrologist, we literally sat down for an hour, and that's unheard of at an appointment. And we went step by step, even to the point of him telling me to cancel an appointment with my endocrinologist just to allow the improvements to be shown. So I postponed it for a month just to be able to go in with the data saying, hey, not only did my glucose level improve, but also my heart rate improved, my hypertension is now well managed, and my kidney function is great. And that left her speechless. So I agree with what both doctors said. Everybody should really be involved in this. And especially as a patient, you should never put a patient in the mix of who's fighting for, you know, that particular ownership of a patient's organ or treatment.
Yeah, terrific. I think, thanks, Patrick. I think Ashley's going to try to unmute Nancy again. So let's see if this, and then I've got another question on the side.
Nancy, I think you might need to unmute yourself. For some reason, it's not letting me unmute you. So if you could maybe try unmuting.
Well, I'm going to go ahead and ask this is an interesting question that came through on the side. It says, at the risk of coming across as Pollyannish, would agitating for more equitable and universal free access to healthcare resources not be preferable to negotiating with payers, pharmacy benefit managers, etc.? Anybody want to take that one?
I'm Canadian, so you don't have to.
No, you can't answer.
You don't have to convince me, and I guess I have to recuse myself. Yeah, we have that already.
Yeah.
Well, and I think that Canada is a great model, but the truth is this is where we are now. So in the meantime, I think this is what we have to do. And actually, today is my clinic. And I rescheduled patients to be here with you today. And right after we end this meeting, I'm going to go back to my clinic, and this is the battle I'll be fighting this afternoon. So I do think that they aren't mutually exclusive. And until and if we ever get universal health care, I do think we're going to have to deal with payers and pharmacy benefit managers. If this afternoon I want my prescription to be accepted for a patient. on an SGLT2 inhibitor.
Okay, any other comments about that?
I take my hats off to the physicians that have to battle with insurers to get prescriptions out to patients. A lot of times patients don't realize this and it falls back on the physician. But I've literally sat, as a patient, sat in a physician's office and listened to the battle of just trying to justify a particular medication that can benefit that patient, not necessarily, you know, a random medication or generic, but the medication that that's better suitable for that patient. So if you ask me personally, I say yes, but I know it can be a difficult thing to do.
The other thing I'll say, and this may be a little controversial, but right before I joined your panel, I was in clinic with a patient and wanted to prescribe an SGLT2 inhibitor, but we knew it would be a battle with his insurance company, and we do have a clinical trial open. Now, admittedly, the clinical trial randomizes them to placebo or an SGLT2 inhibitor, but the patient actually said to me, my chances are better in the clinical trial than they are with the insurance company. Now, there are many dimensions to that. I am an advocate for research for many reasons, but one of them is actually access to care and to get state-of-the-art care, even if it's the placebo group. We'll be more likely to assure, for example, they're on an ACE or an ARB, which is the standard of care, and then a 50-50 chance that they get they get the test medicine. In this trial, it's an SGLT2 inhibitor, but the patient said, I'd rather take my chance in the clinical trial. Like I said, I'm an advocate for clinical trials for other reasons, but clinical trials do promote access to therapies better than at least the U.S. healthcare system does in usual practice.
Okay, you know, I see we are now at the top of the hour, so I'm going to close out and ask Ashley to come back on. But before I do, I want to thank all of the panelists, Patrick, David, and Kathy, for spending the hour with us and for sharing your insights. I am fully confident that with all of you pushing for these new innovative therapies, we are going to win the battle and get these out to patients who need them. And thanks to all the participants and for all the great questions. And interestingly, just an FYI, it says for Medicare patients, SGLT2 inhibitors run about $800 per month. So on that note, we have some work to do for sure, but there is a lot of hope, to quote Patrick. Thank you all very much. Okay.
Thanks for arranging this.
Yeah, thank you.
Excellent discussion. Really appreciate it.
Thank you.
Bye.
Take care, everyone.
Yep. Bye.
Good to be with you today.